So welcome everyone. Brad Richards, the Medical Director, Chief Medical Officer of the Department of Social Services, have been helping co-lead this on the maternity bundle work on the department side, along with Fatmata Williams, and many other fantastic people, including Tiffany and some of in the Mercer team that you'll be hearing from today, as well as the CHN team who helped set this up. So just a few ground rules. This will record and post as you noted. Here we'll also have the materials on the DSS website. If you're not speaking, please mute yourself, and please use the chat for Zoom technical and audio issues only. There's a Q&A feature to post questions anonymously, and we'll be doing that. We'll be speaking to those questions at the end, so we won't necessarily be typing into the Q&A feature, but we will be planning on bringing that up at the end. And we're just excited to have you here as we get closer to our intended launch. I will note that there's some questions that came up about specifically provider billing. We're working on technical details, and those will be forthcoming in the future. So we won't necessarily be getting into the very specifics on provider billing today, but that information will be forthcoming. And we do look forward to engaging with especially provider practices further as we get closer to launch. And so we'll be in touch, and hopefully you'll be hearing from us in a good way and more in the future. So Tiffany, let me pass it over to you.
Awesome. Thank you, Brad. So welcome, everyone. For today's meeting, we'll be giving a brief overview of the program, and then we'll dive into a little bit more around provider attribution, case rate, target price, reconciliation, and the quality measures and reporting dashboard, and then we'll close out with some questions. So to kick off with the program overview, to start, let's ground ourselves with where we are currently with the program. DSS has been designing this program for about 3 years now and is planning to launch on September 1st of this year. There may be a possibility of launching prior to September 1st. And if that's the case, DSS will provide 3 months advance notice to providers. But as of right now, our target is currently September 1st. That go live date is going to be pending receipt of federal CMS approval. So DSS is currently in the process of submitting the state plan amendment. We just received comments from stakeholders through the public comment period. And another priority that DSS is working on with the Mercer team is going to be doing some actuarial testing and program modeling. So this is what we are calling the historic dry run. DSS and Mercer are basically taking claims from 2022 and running the program as if the program was live then, and to see how the program would work in that retrospective view. And then another aspect that DSS is working on currently is just getting the operations ready in terms of program readiness. So making sure payment processing system is good to go, and developing more of those policies so we can give guidance to this group and other stakeholders. In terms of what to expect coming up, out of the dry run, there's going to be 2 key things that we're going to be publishing for providers. The first is going to be provider-specific draft case rates. These are based off of 2022 claims. So that's just to give providers an idea of what their rates might look like going forward, very much draft, as the rates will be rerun closer to dry run, but just to give you an idea of the impact in the program. The second piece is going to be the historic performance reports. These are going to show how providers performed in terms of their quality, and that's also going to give an idea of what their impact to the program is going to be. Some other pieces that DSS is hoping to put out before go live: provider bulletin, give more guidance on payment policies and processes, planning for more stakeholder engagement, more meetings like this provider forum. We also have an advisory council, which is a broad group of stakeholders that DSS has been working closely to design this program with. So more updates with this forum and with the advisory council. And then DSS is also planning to put out other resources, such as an FAQ and resources for newly covered services like lactation supports. So getting into the program itself, once this program launches, DSS is basically shifting provider payment from fee-for-service, the more traditional way of paying providers, to episode-based payments. An episode of care is going to describe the total amount of care that is provided to a patient in a certain time frame. So in this program, the maternity bundle or episode is going to include various services during the pregnancy, delivery, and postpartum. And that time frame specifically is going to be 280 days prior to delivery, all the way to 90 days postpartum. In terms of how payment is going to flow during the episode of care, you'll see here at this diagram in what's going to be the first trimester, nothing is going to change payment-wise. Providers are still going to receive fee-for-service payments. This is in recognition that there are high volumes of miscarriages and other complications in the first trimester. So first trimester fee-for-service payment, then starting in the second and third trimester, providers are going to be eligible to trigger or initiate bundled case rate payments. This is going to cover services in the pregnancy and postpartum phase, and these are services that are going to be provided by the provider, the accountable provider who's responsible for care during this episode. There are also going to be certain services that are still going to be paid fee for service if they're not included in the case rate payment. So we have more information about case rates and what's included in that later on in this presentation. The other thing to call out at the end of the episode of care, there's going to be some time for the claims to be submitted and to do some calculations for what's called reconciliation. This is going to provide providers with the opportunity for shared savings payments. It's going to be upside only, so there's no risk at all to providers in the first year. This is essentially a bonus payment for providing high quality, efficient care. And the reconciliation is basically going to look at the total cost of care, the expected total cost of care compared against the actual cost of care for services that are included in this episode. And any savings are going to be eligible to the provider and distributed based on quality performance. So that is the overview of how this program is going to work essentially. In terms of who is affected and who's going to be participating in this program, the program is going to automatically include all outpatient, obstetric, licensed midwife, and family medicine practices in Medicaid if they meet the minimum volume threshold. So that's going to be 30 births per year. If providers don't meet this criteria, then they're going to be excluded from the program and paid fee for service for all services rendered. So this program is basically targeting outpatient providers, no hospitals. In terms of bundle attribution, we'll get onto this a little bit more later, but basically episodes are going to be attributed to provider groups. That's going to be the tax ID level. The way we're going to identify attribution is through providers billing certain diagnosis codes. Some draft codes are already provided and published on the DSS website, but we'll get into that a little bit later. In terms of different components of the program, one aspect to newborn care, the program is going to include 30 days of newborn care for reporting purposes only. The goal would be to phase in newborn care for financial accountability over time. So this year one reporting only feature of newborn care is going to be able to give DSS some data to apply any year one learnings to year two and beyond. Postpartum care, I already mentioned that this program is going to include 30 days of postpartum care as part of the episode for financial accountability. I will note DSS does provide coverage for a full year of postpartum care. So the full year of postpartum care is going to be looked at again from a reporting standpoint, just to provide DSS more data if the department wanted to extend the postpartum period within the bundle at a later time in year two or later. The last piece I'll touch upon here, how the program is going to handle multiple births. Essentially, multiple births will be included to ensure they have access to all of the other benefits, such as doulas and lactation consultants in the program. The way the multiple births are going to be treated is basically they'll receive one case rate as if it were a singleton birth. And then during reconciliation, additional payments will be made to make sure the cost difference between singleton and multiple births are covered so that those costs are basically reconciled. The last piece that we'll touch on in this overview, very exciting, DSS is providing access to doulas and lactation supports. For doulas in particular, to make sure members have access to doulas, there's going to be basically a dual approach for how doulas can be paid. This is basically a no wrong door approach to make sure doulas are provided to members. So the first method is going to be paying doulas through the maternity bundle. The second way is going to be paying doulas fee for service directly. So for the first method, a bit more information has been outlined in this chart. DSS actually worked with PMC, primary maternity care, I believe, to help think through how to integrate doula care as part of this program. So essentially the way it's going to work in the first approach of paying through the bundle, providers are going to receive what we're calling an add-on case rate, an add-on amount to their case rate payment. So they're going to receive additional dollars that are specifically intended to be used for doula services and lactation supports. That funding can be used for the provider to create relationships with doulas and provide access and pay doulas for their services to the member. The second approach is going to be through direct fee for service for the doulas themselves. So doulas would enroll with Medicaid and be able to receive payment from DSS. This is going to be pending the Department of Public Health's doula certification, which has not yet started, but it should be beginning relatively soon. So that's how the doula piece is going to work within this program. Before I wrap up the overview, I'll just take a quick moment to check the Q&A to see if there's any questions related to the overview. So the first one, will this program include FQHCs? At this point, no, FQHCs will not be participating. The hope is to allow FQHC engagement and participation in the future. But right now, given the complexities of their PPS payment and making sure DSS meets federal requirements around their reimbursement, we're not going to be including them in year one. The second question, does 30 births in a year mean 30 Husky visits or any insurance to qualify as a bundle provider? I believe Husky.
And just to clarify, not visits, it's births attributed to the provider. So just not, but it is specific, just as you were saying, sorry, Tiff, we need to just clarify. Yeah, definitely related. 30 requires to have 30 births attributed to that provider to qualify. Grace, do you want to add anything to that?
No, just want to echo. That's right. That's our understanding as well. 30 attributed Husky members births per year.
And then there's a question on doula quality. Do they have standardized education? Just to say, the process for the two different paths are slightly different. DPH is providing certification to doulas, and so there is a process for certification with requirements. Those will need to be met in order to be a enrolled fee-for-service doula provider. For providers, so similar to nursing or MAs or other staff that providers have on, they will be the ultimately responsible underneath the provider scope to determine who should be enrolled, they should be working with as a doula. Obviously, we can encourage providers to utilize the DPH kind of overview if they're not a certified doula through DPH at the time of launch. I'll just note that DPH, I haven't seen notification. They haven't actually launched the certification, but they are very close to it. And so we are anticipating that happening, we believe, pre-launch at this time. And then I saw 30 births to the provider, to the practice. So at the TIN level, so it's at the tax ID level, that's how we determine whether people meet the 30, at the 30 birth threshold. And then what if you're not a birth care provider for fall? If you're not, I think that might mean if you're not attending the birth. Those individuals can still qualify even if they do not attend the birth. So you can be attributed to the pregnant individual without attending the birth. Our hospitals excluded from the bundle, specifically children's hospitals, since they treat fetal complexities in NICU patients. They're not the attributed provider. This is really based around outpatient providers specifically. So this is really attributing. We know that hospitals play an extremely important role in the care of pregnant individuals and newborns. But in terms of how this is constructed, this is really focused on ambulatory maternal health providers as the accountable folks. So there's no changes in payment to hospitals. They will still receive the same payments that they've historically received. I see a question about quality. Regarding quality, my provider does not do the delivery. She does prenatal and postpartum only. The patient goes outside hospital for delivery. Would we bill our per episode or fee for service if 30 births? So if more than 30 births, you would still be able to receive if you meet the thresholds, you would still be receiving the case rate. You'll still bill as if you had always billed. And so this will get into the billing specifics later. We've tried to make this so that providers who are used to billing the way they historically have really should drastically not impact them. And we are going to have specifics about how you trigger the case rate, et cetera. But if you are a provider that doesn't do delivery, you would still be inside of the bundle or still be eligible for it. And we would be giving you specifics about how to make sure you're billing correctly for these purposes. And you mentioned that the prenatal visit will be paid. Is that the office visit and other services as the ultrasound? Is this in the first trimester? So there, and maybe Tiffany, we'll go back to that slide of what's included, and you can feel free to walk through it. But I'll just say high level is that prenatal visits in the first trimester are still paid fee for service. And the reason that's been done is because there's a lot of pregnancies that don't go beyond the first trimester, and becomes challenging from an operational standpoint to pay case rates starting then that with 25% of cases of pregnancies are and for various reasons before that end of the first trimester. And so that's kind of the rationale. But in terms of what's included, this slide kind of goes over what's included in that case rate, and we tried to build it in such a way that the things that we expect providers to do in practice in their office, in offices, or in generally, or to members maybe on telehealth, et cetera, are included underneath that case rate. Anything else helpful to add there?
No, I think you covered it.
Apologies if this already explained. Are episodes another way to indicate which trimester someone is? No, the episode is really this overarching, and this is kind of included on this slide where we're kind of saying that episode encompasses really this 280 days prior to delivery to 90 days postpartum. That's kind of the full episode of care. Are there any plans to cover doula and lactation consultant services outside of the bundle? So doula, yes, we are. We just discussed that there's two options. Essentially, doulas could be accessed whether it's through directly underneath the bundle through providers, and we're working through a fee-for-service option where doulas can enroll directly as providers. Who is overseeing the curriculum for doula certification? Is it based on national certification guidelines and scope of practice? Who's eligible to teach the trainings? This is definitely outside the scope of what this conversation, I would say. So the Department of Public Health has really overseen the certification process, and that would be the right teams to talk to in terms of how they're determining certification. Can you give us an example in dollars of how this rate compares to the current fee-for-service delivery? We will briefly mention that today. And then for providers specifically, I'm very excited to announce we'll very soon have individual provider rates that we'll be sharing. The goal is to make providers whole based off of their historical fee-for-service utilization pattern. Grace can go into the details much better than I can to explain that, but that is kind of how this was shaped, is to make sure we make providers whole for how they currently are practicing. Grace, do you want anything else to that?
No, I think that's a great overview. I can, in the later slides, we'll break down to each components, and some of the question that, I have heard probably will be answered in the later section where I share the details, but that was a great overview.
Okay, perfect. And this feels like a good segue to move on to the next section.
Thank you, Tiffany. Hi, everyone. This is Grace. I will be talking about the provider attribution, case rate, target price, and reconciliation. So let's go one by one. So this first section I'm going to cover is about attribution. I just want to note this is a pre-launch attribution logic. What this does is to, understandably, historically, we have not had this program in place, but we have a whole bunch of fee-for-service claim history that we can look at and, decide which episode gets attributed to which provider. And I want to emphasize this is talking about provider on the TIN level, right? So that is the level where we will do this 30 cases minimum requirement, as well as setting the case rate, as I will talk about later on. So with this pre-launch retrospective attribution, we go through 3 stages as showing on this slide. And when I say stages, it's a hierarchy. So if there's the first stage that will help us classify or attribute a case to a provider, we just go with the first stage. If not, then we'll move on to stage 2. If not, then we'll move on to stage 3. So there's a hierarchy there. I just want to emphasize. So the first stage we use the logic is to look at global code. As we know, global code is to mainly indicate this sort of care providers have been providing to the members during their delivery and some prenatal and postpartum care, hopefully. So we use global code as our first criteria to identify historically what are those cases can be attributed to which providers. So here is our first criteria, and we use 4 global codes as listed on the slide. If we cannot find any of global code claim in each case's claim history, we move on to stage 2, where we look at the E&M code accompanied by a triggering second trimester diagnosis. So we look at all the second trimester claims, identify a claim where there's an E&M code and a triggering diagnosis code on the same claim. If we find such case, we then look at if there's any other services provided by the same provider during the second or the third trimester, just to reassure this is not a one-off visit. So if both criteria are met, then this case would be attributed to that provider. And then if these stage 1, stage 2, we can't find nothing, then we move on to stage 3, where we looked at the overall second and third trimester claim and postpartum claims to look for claims with E&M code. Whichever provider has the most volume of claims with E&M code, then this episode will be attributed to the provider. So that's kind of our retrospective way of defining episodes to be attributed to a provider. So obviously, as we talked before, this program is meant mostly for the primary care OB and midwife practitioner. So we do want to kind of limit this attribution logic to certain type of provider specialties, as we listed on the right side of this slide. I believe the plan is we will also likely provide a list of providers where this kind of attribution can ever occur. So if you're not a practice, if there's a practice outside of that subset, then even if, based on this logic, you might be attributed, but because the practice type doesn't fit, we won't consider that episode being attributed to the provider ID. Sorry, the TIN. I should just emphasize. So that's kind of our retrospective way of defining episode with their attributed provider. And later on, when we talk about case rate, all the case rates will be also, geared towards the defined provider TIN. And then, as when we move on with dry run, when the go live date approaches, obviously we refresh the data, use the same logic with just newer claim history to define a case rate and, who are the accountable providers meet that 30 cases criteria. But this is the general logic, what we have been using for the dry run. And, in the future, when the program approaches, we'll refresh the data and use the same logic. Let's move on to the next slide, Tiffany. So now we're going to talk about case rate. So case rate, again, like I said, the way we define attributed provider is based on logic on prior slide. And case rate is also in the same fashion. We take a look at all the claim history from the, we take a look at all the claim history from the attributed provider for all of their attributed cases, and then summarize them and then divide it by the the case rate payment counts to get to the monthly case rates. So that's the general logic. But we do want to emphasize prospectively speaking. So when the program go live, the attribution obviously cannot follow the same logic, because you don't, when a member is in the second trimester, you never know who will build the global code. So obviously that logic cannot apply. So prospectively speaking, we will look at the trigger code happen during second or third trimester. So if there is a, with a case, there is a provider build a claim with a trigger code during the second trimester, this claim will be attributed to that provider, and then the provider will start receiving the case rate instead of the fee-for-service claim reimbursement rate. So as Brad talked early on, the billing practice will follow pretty similar with what you guys have been doing, but the system will identify those trigger events. And instead of paying the fee-for-service rate, a case payment will occur after that claim is received and identified. So that's how we're going to do with the prospective attribution. And just want to emphasize also, if a case has been attributed to a provider, but later on maybe a different provider, under a different TIN, send or build another claim with another trigger code, then, or the same trigger code, doesn't matter, have a trigger event happen, then the case payment for the original provider will stop. And then the second provider will take over that case rate arrangement. And, if the same provider, the first provider had another billing come in, but with non-trigger code, you will get the normal fee-for-service payment rather than case payment. So that's how there will be the attribution shifting among providers based on the trigger code. All right. Again, the third bullet point talking about the actual, the case rate will be the same, the payment will be the same regardless of the episode severity level, because the case rate was set up in the sense that we lumped every, all different severity level of cases together and get to the average. So there will be cases where it's more severe or less severe. So you will still get the fixed, the prefixed case rate. So that's the prospective sort of payment logic and idea. And then on the right-hand side, we can look at the different services that will be paid or will be covered by case rate prospectively. We do want to update. This is something we've shared before, but we do want to update you all that as of right now, we decide to include professional delivery fees into the case rate payments. So, that does not include any hospital or facility claim. That's just strictly the professional delivery fee that professional delivery that accompanishing the birth event. So those will be bundled together with the rest of the professional services as part of the case rate. Next slide, please. Thank you, Tiffany. So here, so right now, preliminarily, as Tiffany mentioned earlier, it's a dry run phase. What we decided on the current dry run performance here would be 10/1/2021 to 9/30/2022. So the case rate is supposed to set a year prior to that. So the current case rate we use to identify or to sort out the logic is for the birth or the delivery between 10/1/2020 to 9/30/2021. So preliminarily, we've got to a point where the case rate among providers range from 300 to 500 per month. Again, this is a very, this is for majority of the accountable providers. We have noticed some outliers where they have maybe case rate slightly above 500 or below 300, but for the most part, they're between 300 and 500 per month range. And as noted, prior to the go live date, we'll refresh the data using the latest time frame of claims to reset this case rate. So those will be using more up-to-date information. But as of right now, for the dry run, the time frame we're looking at is, about 3 years prior. So, and then we will provide a provider-specific case rate before the end of Q1 this year, just so, again, use the same dry run period, but at least we will have a 10-level specific case rate for you all to, review and ask question and such. We do want to note, on top of this case rate, we've been, between the 300 to 500 range. DSS is planning to make additional add-on payments of $21 per month to cover the doula services as well as the lactation supports. And the breakout is $14 for the doula, $7 for the lactation support, and for the for the doula portion, we will go through at the end of the performance year 1, we will go through a reconciliation process, just to recognize providers that have more doula services, and then ensure there's some, some financial, ensure that you're not taking any financial loss for additional or, above average doula services utilization. So that reconciliation is separate from the share saving, this whole bundle arrangement reconciliation afterwards. It's its own true-up process that we will perform once a year towards after the end of each performance year. And then for the draft case rate distribution plan, as noted on the bottom of this page, is we're going to finalize the case rate, and then we will share that with the public, with you all, and then we'll have the engagement opportunity so that we can, answer all your questions and take all your feedback as well. So next slide, please. All right. Let's talk about target price. So again, holistically, case rate is a sort of PMPM payment that will be made ongoing prospectively during the whole performance year. And then what we will do as, the incentive part of this program is set target price and reconciliation to identify savings that each provider have, generated. So the first part is a target price. So the target price is a term we use to basically sort of predict what each episode will cost based on the prior year's experience. So target price is a overall episode cost that include first to the third trimester, delivery cost, and 90-day postpartum. So this whole entire 280 plus 90-day experience, all those maternal related costs will be part of the target price. So as we see on the table here, pregnancy, delivery, and postpartum, they're all going to be part of the target price. And this will include all the in-house, meaning the services generated by the attributed provider, or the ones that are not attributed by the provider, including like, hospital service costs, all the lab costs, all the pharmacy costs. All those will be considered as part of the target price. And as a way we set it, it's going to be based on the prior year's overall episode cost. And then we trend it and use risk adjustment, C-section caseload mix to come up with this sort of benchmark as of what the preset price episode cost will be, and then we use the real cost to compare against it. So target price will be a per episode benchmark price. Next slide, please. All right. So we do want to call out there are certain scenarios where some cases will be excluded from the target price, right? So as we see the first 6 bullet point where, the member's age is younger than 12 or older than 55 will not be part of the target price setting. We won't take that case into the target price consideration. Or when a mother left the hospital against medical advice, that is also a case where we will will be excluded from the target price setting and reconciliation. Or if there's substantial gap in the enrollment, so the member maybe weren't Medicaid eligible for a good, several months or so, this episode will also be excluded, understandably. And then, or if there is an orphan claim where there's no facility claim, meaning any claim, if we cannot identify any birth center claim or the hospital delivery claim, in those cases, episode will also be excluded. And also the last two are when the baby is stillborn or the mother decided to take abortion or the baby is miscarried. So whenever that event is identified prospectively, the case rate will stop being made. And also all those payments or all those costs associated with those cases will be excluded from the target price, as they will, obviously skew the results. There's also other situation where we will also, the case rate will continue throughout, but when we do the reconciliation and set target price, those will be the cases where, they're not going to be part of the target price setting. So those includes pregnancy where there's no claim incurred during the first 2 trimesters of the pregnancy, or when the baby is born with, it was born with a severe congenital anomaly, or they cannot be linked to any delivery episode. So those cases will also be excluded. Right. So here is, a framework where the steps we're going to take to set the target price. Again, like I said before, the idea of target price is to use historical claim and make modification to those historical claims to set a benchmark price for the performance year. So a couple of things we do. I'll just describe step by step. We usually take we look at all the claim history. We standardize inpatient claims or some other specialty type of claims to standardize some of the claim cost. Then we Winsorize some outliers, meaning for each episode after standardization, we get to an episode overall cost, and we look at the 5th percentile and the 99th percentile. If there's any episode below 5th or above 99th percentile, we'll cap at the 99th percentile and make sure, the ones under 5th percentile get the 5th percentile's cost. So we Winsorize the outliers. Then we use we will trend those historical price to the performance year, understanding that there's sometime, fee schedule adjustment. So we implement the trend to reflect that the change between the prior year to the performance year. So after all that, standardize and trending, we will get to the risk adjustment, which will incorporate both health risk score and social risk score together to come up with a combined, a budget neutral risk score for each provider. We use that base period risk score to risk adjust each 10 levels aggregated episode cost. Then we use that as 50% of weight to combine with the statewide historical price. So we do a 50-50 blend between the statewide historical price with the 10 level specific risk adjusted historical price. Then we combine them together into the base price, again, differentiate by each provider 10. So we call it base price. Then we use base price to combine with the actual performance year risk factor. So the reason being, there are cases where during the prior year, the episodes a provider take may be less risky than what they actually have to, provide care for during the performance year. So this kind of risk neutral base for the base price. And then again, risk adjust to the performance year is help to justify those member acuity differences between those two periods. So that's a process we're going to take to get to the target price by provider. And then we also are, implementing this caseload mix change, considering the C-section mix rate differences, just because we understand they're a lot costly than, the vaginal delivery. So we'll factor that in as well for our target price for the performance year. Right. Next slide, please. All right, so we're going to talk about reconciliation here. So now we have every pieces together. We have case rate that will be paid prospectively on a monthly basis. We have the target price we'll set at the end or after the performance year is finished. And then we will come up with this reconciliation. The goal for the reconciliation is to compare this target price benchmark with what actually have been paid to the provider. So as you can see, as the formula on the slide, there's target price, which is our benchmark, minus the actual cost. So the actual cost will include all the fee-for-service payment each provider receive, plus the case payment they receive on a monthly basis. So those together will be the actual cost. So the difference between these two will be the net savings. So this process, we do after the end of the performance year will happen no later than 6 months after that. We usually will probably leave a 3 months of run out for claims, but this will occur between the 4th month and 6 months of post performance year ends. And then the bundle will, and this reconciliation will be performed once every year, but we do plan to have a quarterly reporting exercise so that all the providers can monitor their performance over time. And then for year 1, we do want to highlight, in a case where the saving is negative, providers will not be responsible for any of the losses. Next slide. Yep. So here is just a general timeline we want to indicate. We do want to note this will be for, right now we indicated as of the go live date is July 1, 2024. So if we go with a plan as the go live date is 9/1/2024, everything will just shift 2 months later. But as an indication purpose, if the performance year is from July 1, 2024 to June 30th, 2025, we will preset all the accountable providers case rate, who are the accountable provider, and what the target price might be 3 months prior to that. So you guys will all know what your case rate will be, and then we will set this using the calendar year 2023's claim experience to define the list, the case rates, and the risk-adjusted base price. And then after obviously during the performance year, we'll have the quarterly reporting just to keep track. And then afterwards, 3 months later, we will take all the actual experience during the performance year to reset to refinalize the accountable provider list, their target price, and then the share saving amount and quality measure, all that good stuff. So, we will do that, like I said, between 4th to 6 months post end of the performance year. So that's the general timeline we're looking at. I probably should pause here to take questions before we jump into quality measures. Or Brett, maybe we will do that at the end. Either way, I'm fine.
I think it's probably reasonable if we want to answer some of the questions here, Grace. So happy to start at the top. One, I think, goes back a little bit to some of the prior conversation, but how will international board certified lactation consultants, IBCLCs, be integrated into referrals and payment both through the OB offices and fee-for-service. As of now, for lactation services, we will be providing funding directly through the add-on payments, as Grace outlined, to providers. They'll have general requirements that we will ask providers, including making sure that IBCLCs are available as needed for members who meet that level of need. So that is where we stand. Just to note, some of you may be familiar, there's not currently a certification process going on. DSS did participate in a working group with some of the legislatures on this topic. Just make sure that all of you are aware this is something we are tracking and will continue to follow. Will case rate publications be mailed to practice primary sites or claims billing address? Great question. We're working on making sure we have a communication plan in terms of communicating case rates to individual providers at the TIN level. If there's any suggestions, we will be working with CHNCT, who engages a lot with provider practices, to set up a communication plan. If there's any suggestions, we welcome hearing them. What about the non-defined provider? How do they get paid for services rendered? For example, an OB provider performs a triage assessment, does a physical exam, a bedside ultrasound, and a non-stress test, and discharges the patient back to the routine prenatal provider. So it depends on if that provider is a enrolled or is a maternal health provider that meets the 30 birth threshold. If they meet, so say there's a let's say it's a maternal fetal medicine provider, MFM provider, and who is seeing a member who's referred by their OB for a specific reason. If that MFM provider, maternal fetal medicine provider, meets the 30 birth threshold, they would get their case rate for that month. If both providers see that member in a month, both will get, and they're both eligible, they would both get the case rate in that month. So just to say, again, both would get paid. If the MFM provider in this example doesn't meet the 30 birth threshold, all those services would be billed fee for service, and it may stop the case rate from the other provider until the original OB provider that's, let's say, meets the 30 birth threshold, sees the member again in a subsequent month and reestablishes that they're the primary OB moving forward. Grace, do you want to add anything to that? I just want to make sure.
No, that is actually spot on. So so if I was attributed provider for the past 2 months, and then somebody else submit a trigger code in a claim, no matter if they're accountable provider or not, this case will be attributed to them. What that means is that unless I bill a claim during that month when the trigger happens, I will still get that month of case rate, but afterwards my case will stop coming in. And then the other provider, based on their own situation, if they're accountable, they will get case rate. If they're not accountable, they will get fee for service. But this case is no longer associated with me. What will happen in order for me to regain this case is I will need to, in the subsequent month, resubmit a trigger code. Then this case is back to me. So it's kind of, it's a separate event. It's the trigger happens no matter, it's separate, 2 different parties. So this case will belong to me, no matter who the other, as long as the other, the case will belong to the second provider, no matter what they're accountable or not, as long as they have a trigger code, that's theirs.
I see. Does Husky reimburse for initial non-revisits via telehealth in general, or will this just be for the bundle? I think we'll need to go back just to make sure our language is up to date with what the current Husky Health policy is for telehealth. We'll want to follow that, but in general, telehealth visits would fall underneath the bundled services in terms of being provided. So that would be expected kind of underneath those payments. It would be underneath, telehealth services would be underneath the umbrella of the case rate that's been developed. If a provider does the first trimester and then transfers the care to another provider, will this group get fee for service payments? It depends. If someone sees one initial OB, they meet the 30 birth threshold, they're getting the case rate. That member transfers to another OB that's also meets the 30 birth threshold. They would then initiate the case rate for themselves once they've submitted a trigger code and with diagnosis.
And sorry, I just want to add there, even if the provider has been providing service for the first trimester, without them submitting a trigger code claim in the second or third trimester, this case will not belong to them. So there has to be a trigger event happen during second or third trimester to identify this case belongs to or is attributed to a provider, no matter what happens during the first trimester.
If identifying providers by tax ID, how will you separately reimburse MFMs on a fee-for-service model when they bill on the same tax ID as the outpatient hospital OBGYN? So if a group at the 10 includes both OB providers with MFM subspecialists, and they meet the 30 birth threshold, and again, they're all organized under the same 10, all of that would go into making the case rate, including the MFM provider's practice. So assuming here, let's say the clinical complexity of the care that's being provided for individuals seeing MFM providers requires more care, and we see higher levels of service delivery historically, that will impact the case rate and would shift it potentially higher in general. The case rate would then be utilized across the entire practice. So it is, again, kind of a global case rate at that TIN level. Hopefully that answers. Grace, do you want to add anything to that?
No, that's spot on. Yep. If there's higher cost services provided historically because there are MFM practices within the 10, that will be factored into the case rate that we preset.
And we are, and as Grace, I'll just make sure to emphasize, we will be looking at trends in terms of utilization patterns, et cetera, over time to adjust those case rates.
Yes.
So anything else you want to add to that?
Nope.
OB rates have not been, oh, sorry, go ahead.
Yeah, could you repeat that MFM will be considered in global? That was a question I received.
MFM, yeah. So if an MFM provider practice, either that's individual or as part of a provider of a private group, that is included underneath the case rate for that has been developed. That helps. So whether it's a independent provider 10 that's just MFM providers, or there's 10 tax ID number that includes both MFM subspecialists and OBGYNs, generally that gets pooled together in terms of that case rate development. OB rates have not been updated in a long while and are far less than the cost of care. Will the new case rates include an increase to address historical underpayment and to support the increased management responsibilities? So some of you may be familiar that currently DSS is undergoing a rate study that was approved by the legislature. Phase 1 has concluded. We're now moving on to phase 2. There are ongoing discussions with the legislature, which I'm sure will be happening this session in terms of rate changes. As of now, there was not additional funding put into this. However, I will note that there are opportunities for shared savings that would yield additional potential dollars as we look to increase quality and reduce unnecessary C-section rates, and also decrease adverse events that may have additional costs for them. So there are opportunities to receive additional dollars through this without any changes. However, I do just want to note that reimbursement rates in general are being looked at across the entire spectrum at DSS at this time. For the first 2 years of the program, will there be a reconciliation of the case rate against fee-for-service billing for each practice to help protect providers from any risks associated with the new model? So I mentioned a little bit, and Grace, you may want to answer this more specifically than I. We will be looking at doing a reconciliation at the end of each year or each performance year. And I think maybe the question is, are we reconciling this historically, which is not necessarily the case. We will be doing this moving forward. So we adjust case rates if there are changes in practice patterns over the course of the year, again, looking at trends in that utilization. So just wanted to clarify. Grace, anything you want to add to that or specify? Yeah,
that's my understanding too. But if the question is the reconciliation defined here is to say whether we're going to have a process where we look at as if the claims are not zero paid, as if they're fee-for-service paid, and comparing that with the provider's case rate payment, in reality, I mean, Dr. Richards, keep me honest here. I don't recall we plan to have that process in place, but that's we can take this back and see if we can do that, after year 1. But as of right now, I don't recall we plan to perform it or do that exercise.
And generally, one of the goals of this is of moving to this case rate model is really to try to provide more flexibility for providers to provide services as needed for members, rather than having to say we need to drop a CPT code to make sure we're generating revenue. So that's part of this reason. We know this is a somewhat of a shift in framing, and will take some time for providers to adopt and think through. We are have been in, just so you know, other. You're like, well, DSS is the only, or Medicaid and CHIP are the only payers. How do we do this? We have been in talks with other payers about this shift, as well as the state employee health plan. So just to say, we recognize this will take a little bit of time to adopt, but we do anticipate and hope to see providers take on the opportunity for additional flexibility to provide more tailored services to members through the flexibility that the case rate will offer.
Yeah, and also the sort of the reconciliation is kind of like that if you think about it, because like for instance, for year one, as an example, we will look at the prior year, which are all paid fee for service, right? So we use those, the fee for service payment results and then trend it and make all those, standardization and come up with the target price. So in a way, target price is based on fee for service, and that is, that might generate additional funding for providers. If in the case rate scenario, you have less cost than those target price indicated. So there is some kind of reconciliation, but just want to throw that thought idea out there.
Will the state provide a list of certified doulas and lactation support? How does the provider indicate these services are used? Will a list of trigger diagnosis codes be provided to providers? So in the last one, definitely we will have a very clear list of trigger diagnosis codes as well as billing specifications that will be forthcoming. In terms of certified doulas and lactation support, is there a list of certified? No, similar to we don't have a full list of all primary care providers. We do have a list of enrolled providers in Medicaid. We would, for fee-for-service doula providers, we will plan on also doing that. But for doulas that are utilized through provider practices, similar to how we wouldn't have a list of providers that might be working just directly for the practice, non-billing specialist, for example, or a MA or nurse, or example, we would not have that list. So if you're not a directly enrolled provider, we wouldn't necessarily have that list. DPH may be developing a list. I'm not sure in terms of who will be certified. That may be something that they will be facilitating. In terms of documenting utilization, so there will be for those who are familiar with the OBP for P encounter forms, we'll be using a similar mechanism to help track utilization of certain services and capture some data for those using the maternity bundle. With all due respect, why would specialized MFM care be considered the same as general OB care? And my apologies if I made it seem like I was saying they're the same. We definitely recognize the importance that MFM providers, services that they provide, and that are different from general OB. Just to say, in terms of how we've developed a case rate, we've included MFM provider services, recognizing they are providing higher intensity of services for specific for people that are higher risk oftentimes. So that's all I was trying to say. So apologies if it came across conflating them as being the same. With financial models, will financial models be provided to allow practice to see how this model will affect them? Without this, I fear many groups will opt out of this complex payment program as the patients are costly to care for without great knowledge of financial expectations. So that is definitely what we're doing in terms of our dry run. So the case rates are forthcoming. We just alluded to them earlier. The dry run will give practices an idea of how they perform in the program in historical sense. Obviously, you're not able to change your practice patterns historically, but it will give you a sense of what would have happened in a prior year's time frame. And hopefully that will help, especially with which I understand the concerns people have about a new program. We also are developing this in a way that, if you're billing your services as you do today, even if you don't change, you will likely start the case rate even unintentionally. And so that's how we really try to construct this, is making it so you don't have to necessarily drastically change your billing patterns at this time. We will ask you to be very mindful of that. But even looking back historically, many providers would have already triggered this because we're using commonly used CPT codes and diagnosis codes for maternal health providers. Grace, anything you want to add to that?
Nope, you covered it.
Yeah, so hopefully it's not actually it might sound quite different, which I think there is a lot of different complexity to how we're developing this. But in terms of operationally at the practice level, I think it will maybe seem less, there's obviously some added complexity, but in terms of, if you're seeing someone in office, you bill an E&M code, you use a second trimester diagnosis code associated with it. That, and if you meet the threshold of 30 births, you would trigger the case rate. So just to say, it should actually hopefully be not as complicated as it might seem. And this is where obviously it's on us, on the DSS side and the broader team, to provide you with more information so that you can ask questions. And we know that giving you the dry run information will be very helpful to providers to understand how they'll perform historically in the system, what it looks like, and ask even more questions. So I just want to acknowledge we need to do that. It's a really important part of this. Will this information in the presentation be published? We have both MFM and OBGYN. I want to make sure we are understanding and educating based on the updates for global management of a patient who sees both OBGYN and needs to be seen by MFM. Thank you. Yes, this will be published and online. It's on our website. There's a recording. If you just even search DSS Connecticut Maternity Bundle, you'll find the website, and it has a bunch of our old information, as well as this. It will have this on there as well. Will there be more comprehensive training offered for billers and coders in addition of this change? Yes, we will produce our relatively extensive provider bulletins and documentation that will be coming, that is forthcoming. Would existing groups of doulas be able to be on the list for direct fee for service, or would they only be individuals? How would coverage be handled? Can fees be split? Groups be on the list. In terms of, not sure I'm completely tracking, is this maybe asking if a group, if doulas can enroll as a group practice potentially versus an individual fee for service? It's a great question. I think we can take that back and clarify. We haven't finalized the fee for service doula component. We do have to wait on the DPH certification process, but I think it's a good answer, and we can take that back internally. So thank you for that. Yes, there are a few groups throughout the state of the comment, so appreciate that. Yep, we will. We'll look into that. So we'll try to bring that back to the next provider forum with some information. All right, Grace, I think next section.
Yeah, I will hand it over to Sean to cover the quality measure and the dashboard. Thank you.
Okay. All right. Hello, everyone. So just to kind of set the tone, as part of this whole bundle and the model that we've been talking through, quality metrics is another key component of that design. It's really designed to help us ensure that we're able to measure outcomes, how quality of care is going, and to also influence some of the financial aspects of the model for providers to be able to earn extra incentive for high quality care. So that's a little bit of a backdrop of the importance component of the quality piece of the design. As you see here on the screen, we have measures organized into two categories. We have both pay for performance measures and pay for reporting measures. And each of these are weighted and given a value to then inform the calculation that we'll talk about in a moment, which allows providers to have an opportunity for that additional performance payment in the shared savings component of the model. The other piece to point out here is that as we look at these measures, we've heard feedback from a variety of places in terms of, which measures are most important, which measures have the most accessible data, which measures you can provide the biggest impact on. And so I think that we have to have a starting place, and these are measures that we have found have available data and that folks can impact and tie directly to the design as discussed today and previously. So as of now, this is the current decision on the measures as well as the assigned weighting as we prepare for launch. So if we can go ahead to the next slide. One of the things that I think important to point out in what we are trying to put together in the model is we wanted to ensure that as we consider the model, we wanted to have both top performers be rewarded as well as promote improvement from all practices in general to then ultimately get to the ability to bring down some shared savings reward. So in order to do that, we looked at both a performance tier calculation, which is really more related to peer performance across all measures, and then also look at an improvement tier calculation, which is focused on the historical performance, and it will generally have a baseline from that historical performance, and then look at percent improvement over time. And so you'll see in this illustration that we take that data, we look at it in both buckets, and on the next slide in a moment, we'll talk about the various tiers within each of these. And then the idea is to bring forth a final score of the max, meaning which is higher, the performance score or the improvement score, to then feed into the various tiers of performance in the calculation for shared savings. This is, as I said a moment ago, helps to try to support the idea of keeping in mind reward for top performers as well as reward for improvement across the practices as a whole. So if we can go ahead to the next slide. All right. So as we look at this a little further, this shows you how we are anticipating to go through the various steps for each, the performance tier score calculation and the improvement tier score calculation. So if we want to normalize each pay for performance metric against that historical year minimum and maximum, and invert those appropriate metrics so that the higher score is better. So we want to make sure that that is taken into account by each metric, and then utilize those weights, as I mentioned a moment ago, to feed into the calculation of that final composite performance score. That is then given, as you can see on the right, an overall performance tier or rating to show where you may lie in terms of meeting that performance percentage shared savings. Okay, that then is looked at alongside that improvement tier as shown in the previous slide, where we're really looking at, following those same steps of calculation as mentioned for the performance tier, but then take the difference in the current pay for performance score from the historical. So as I said a moment ago, we're looking at more the peer performance on the performance side, that historical comparative performance on the improvement side. And then, as I mentioned again before, we would look at the maximum percentage for the shared savings earned between the two scores and select that for the final percentage of the shared earnings for a particular provider. Once we get those scores, we look at these various tiers, and that helps us when we are looking at the quality gate, as well as the scores for each of these tiers. So if we can go to the next slide, this further illustrates the concept of the quality gate and the idea that the focus of this model is to really help everyone to improve and to maximize the ability for providers to earn an incentive. So you'll see here, if we consider those letter grade tiers on the last slide, if we have a situation in the current year where a provider is on the low end, so that lowest tier, which would be an F in both performance and improvement tier, we want to try to help move that provider in the right direction, right? And so the idea is we would work together to have an improvement plan. You would have an idea of which metrics would be impacted based on that data and your individual results, and then move forward to the subsequent year with the goal, of course, of trying to improve you along towards provider eligibility for that shared savings for the performance period. So we really are trying to create a model, like I said at the beginning, where we're trying to move the whole system in the right direction and have opportunities for that additional incentive for providers. So Grace, did you want to say anything else on those last couple slides before I move on?
No, Sean, you covered it all. Thank you.
Okay, so if we can go to the next slide. This is just another illustration of model results. So if we take the data that we have and run it through the weightings, we have this, distribution of shared savings level achieved by the score type that we previously described. So this is one way in which we would be then looking at the distribution. Again, you have the performance tier, you have the improvement tier, and then the maximum of those go into your final score. And the goal is, to get everyone closer to that 100%. You'll see here that the vast majority are averaging somewhere in the middle. And our goal, like I mentioned already, is to move everybody to further along that percentage distribution. So if you can go to the next slide. So these next couple of slides are just, these are work in progress. The other thing we're working on in the quality area is identifying how we can pull together a dashboard to be as useful and productive for the providers in the system as a whole. So currently, the dashboard that is being mocked up is at the TIN level, and it is set up to track a variety of things. One, just as in the last slide, the dashboard would be able to monitor and track that percent of earned shared savings. And we can do that both by performance metric, improvement, and final. What you're currently looking at right now is all combined. We can look at this by TIN, as I said, or the system as a whole at this time. If you go to the next slide. Another slice of the data, and this was based on feedback, is we can begin to pull in and define the reporting measures themselves and the overall measure description, the categories in which they fall, so whether they're reporting or performance. And we had been starting to pull in excluded membership. We're going to look at that a little bit further to see how useful that would be from a dashboard perspective. But this gives you a snapshot on the kinds of kind of resource and support information that we could pull into the dashboard to make the data as meaningful as possible when this goes forward for launch. And then the last just screenshot sample, this again allows us to look at individual metrics, and we can look at it in a variety of ways. We can look at the overall rate. We can look at the distribution across providers by rate and reporting measure. We can also look at it by periods of time, by fiscal year. One thing I will say is we are trying to determine the most meaningful frequency of this data, because we need to make sure we have volume and scalability in a way that is not going to misrepresent performance. So for example, right now on an annual basis, there should be a good amount of data for each measure. But the more you start to slice that, whether it's, every 6 months, or if you go to quarterly, the volume gets smaller and smaller, particularly with this population. And so we have to be really careful that we consider that before, final decisions are made related to frequency, because you don't want to have data that's not valid or that, doesn't have enough volume to make it credible. And so those are things that we're still working out related to the dashboard and ensuring that what is represented is most meaningful for the system as a whole and the providers. So anything else, Dr. Richards or Grace, that you would add behind the quality measures, the weighting, the tiered approach?
I'll just maybe add that on the maternal adverse events measure, just note that we have heard providers, I think as mentioned or alluded to, that like we've heard the concerns, and so that weighting has decreased. And we definitely want to continue to hear feedback. We know that some of this will need to be adjusted over time, and we anticipate continuing to engage both before launch and also after launch, and hearing from the provider community and broader community as well about especially our quality program and the program as a whole. So I guess that's the only thing I'd add. And Grace, feel free to jump in if you have anything else.
No, I think that's it. I don't have anything else to add, Sean. I think you covered pretty well here. Thank you.
I see there's some questions. Happy to go back to those. Anything else, Tiffany, before we do that?
I might just take us to the next steps to close that out before we get to the last of questions. So we've touched upon this a little bit, but just to let you guys know what's coming down the pipeline from DSS. So currently working on the state plan amendment, the dry run or actuarial modeling, and then operational program readiness. In terms of what to expect, so there are some resources and guidance around doula services. So that's on the DSS webpage. There's a specific doula integration tab for that. In terms of the case rates, we're hoping to publish that as soon as possible by the end of the quarter. Provider bulletin, those details are also forthcoming, more information about billing policies and payment processes. And then also as part of the dry run, providing folks with the historic provider performance reports to give a view of anticipated performance in the program based on claims data from 2022. And then we'll have additional provider forums based on all of the information that's being shared, as well as resources around lactation supports and services. So with that, I think we can go on to questions.
Thanks so much, Tiffany, John, and Grace. So the next question, with the maternal mortality crisis, our OB patients are already in need of more support, more education, more care coordination. OB providers are also tasked with diagnosis, management, treatment of perinatal mood disorders and hypertension, but with the bundle, we will not be provided support to provide this specialized care. But part of the bundle will drive care into these areas. I think it's a great question. So of note, we are looking to shift how we're paying, though the only additional dollars have been added at this time, at least in the upfront, go for lactation support and dual support. But there are back-end dollars for quality gated cost savings that can supplement, and there is the rate study that is being done looking at rates comprehensively. With that said, I understand the concern that's raised that there's a lot of need, and how do you provide more meeting those needs when essentially we are building we're changing how we pay without necessarily increasing payments directly to OBGYNs specifically. I'm hoping that the structure of this bundle encourages providers to think holistically and to focus more holistically than maybe you're able to in the existing fee-for-service structure, which often emphasizes volume over value of service provision. And I think most providers want to provide high value care to members, but often are constrained by systems. So hoping that this provides additional flexibility to focus on some of these things that were outlined for those who really need more service. And so right-sizing the service for the person in front of you. Acknowledging that there's still challenges, and this is not a perfect solution. I don't think we think it is. We hope it's a step in the right direction, acknowledging there's more that needs to be done to really meet all those needs. For the C-section birth metric, what will be the goal NTSV rate to receive the full pay for performance refund? So there'll be two options. So there's a improvement tier. So our existing NTSV rate, and I don't have it up in front of me, it's approximately 31%. And we're one of the, oh, thank you. You might have it, might actually have what our NTSV rate is. Oh, this is just the quality measures, but just in terms of the actual rate across CSS is about 31% of members currently have meet criteria to have NTSV or have NTSV C-section rate. And so we'll be looking at both rate of improvement as well as looking at it as a tier in terms of other performance. So it's kind of a two-pronged approach in terms of how people can actually score on it. I know we'll have to revisit this. Has come up previously about what's the lowest NTSV rate that's reasonable. I think as of now, After talking through this with the maternal advisory council previously, that this is where we'll be starting with our quality measures, acknowledging we'll need to adjust them over time as either we see improvements and or we think we're plateauing in terms of ability to see further changes in that specific measure. For the pay for performance measures, we'll be able to submit flat files with required data. I don't know if our CHN-CT team is on, if someone is on to answer that. That may be something we have to take back and get an answer to for you. But let me pause and see if there's anyone on that can answer that.
I do
Oh, go
also-
ahead. Sorry.
We'll have the CHM team confirm and circle back for follow-up.
Sounds good. Can you clarify the preterm birth labor measure? Will you be counting just the preterm births? Many patients are admitted to preterm labor, but go on to deliver at term. This is the pretty standardized preterm birth measure. So there's a specific specifications which we can include or send out as follow-up. They should be posted on our website, but I think maybe we can make sure we have those so that it's clear. But it really has to do with it's kind of what's classified as preterm birth compared to number of total births that are not considered preterm. So there's a very specific definition that we can make sure we send out. What is the best way to connect our practice administrators with these draft rates? We definitely welcome. We have again, we are fortunate that I think our CHN-CT colleagues that we all work very closely together have a lot of connections with existing practices, and so we plan on using those connections to help us connect with practices as we roll out the case rate information. So, but if you have if you'd like to, feel free to let us know if there's someone you want us to reach out to or specific, and we can make sure to take that back as we're looking to do this. We definitely want to be actively engaged with practices as we provide this information. We see it as a great opportunity to communicate back and forth and answer questions with all of you. What types of quality metric improvement plans do you foresee, and where will those come from? Will they be specific by provider or by TIN? So we'll be doing, again, based on the TIN level, these will be TIN level summary measures. We are working on exactly what the improvement plans require, so there's more to come on that information. So we don't have a specification on that. But if a patient is seen in pregnancy by a hospital-based diabetes clinic or behavioral health clinic who uses the same TIN as the OBGYN, will the diabetes behavioral health rate be reimbursed fee for service or in the case rate? So if you're providing behavioral health, that is all completely fee for service. If it's hospital-based diabetes, specifically if it's outside of it, so if it depends on which the provider type is. If that's provided in the office of the OBGYN and that's currently being billed, and that's, so say it's the OBGYN or certified nurse midwives that's doing diabetes education, then that would be included, and that's currently being billed, that would be included in the case rate. And Grace, I'll turn to you just to make sure I'm getting that correctly. If it's separate and there's a different provider type and specialty, or behavioral health, even if behavioral health was in the same clinic, but it's again a behavioral health provider, those will still be paid fee for service as they're being paid today. Grace, just make sure I'm getting that correct.
Yes, so ultimately what decides on what gets included to the case rate or not is the billing provider. So if the billing provider is following the same TIN as one of the accountable providers and as the attributed provider, that claims cost will be baked into the case rate. But if it's a billing provider is outside of that TIN as the same TIN was the attributed provider, that cost will not be part of the case rate. And as an ongoing the prospective payment, again, that will be based on the billing provider. If it's not the same as attributed provider, that claim itself will get fee for service. So they won't go nowhere. It's not like they're going to disappear. They will get paid, covered either under the case rate or covered under fee for service. Really, the key is the billing provider, whether that is the same TIN as the attributed provider as of that month or not.
As well as an eligible provider type and specialty too.
Yeah,
absolutely. Especially for that's important to call out because behavioral health, even if you're under the same TIN, would not fall underneath we would not have pulled that into the case rate because they are behavioral health providers, that type in specialty. So I think that was the last question. As of now, so I think just to say, I think we're right about at time. And Tiffany and Grace and Sean, thank you guys so much for helping with this. And thanks to the CHN team also for helping organize this. We look forward to continuing dialogue. You'll be hearing from us further for one, obviously, as we want to talk about specific case rates with providers, as well as we'll be wanting to host additional provider forums to have ongoing dialogue as more details come out. We know, again, we are looking forward to continued engagement. We know this will require ongoing dialogue and work to make this work well, and we really do want it to be successful. We think it's imperative to improve the health and well-being of our members, especially those who have been historically marginalized. And we see this as a step forward towards that, knowing there'll be more steps along the way needed to really continue to reach that goal. So thank you all, and we'll be in touch.
Thank you.
Thank you.